Well, good morning. Are you nervous? Not about this, but what's going to happen to you in the next couple of weeks. Well, you should be. Let me tell you a little bit about the background, how this actually occurred. You know, I was raised in the era of vascular fellows, and it was pretty easy, to be honest with you. We were just kind of given a fully trained general surgeon, and all we had to do was teach them vascular. Then all of a sudden, this idea of the integrated program came along, and all of a sudden, you know, a group of surgeons were being handed a group of medical students. Well, and this is Dr. Eric Peden, he's the chief of the division of vascular surgery here, and he'll be joining in some of the discussions. So all of a sudden we were being given medical students, and we were expected to teach H&Ps and vascular anatomy. It was pretty basic, and it was a bit of a culture shock for those of us who'd been probably got into vascular surgery because we didn't have to deal with interns anymore, tongue in cheek. And so we decided to kind of build something for our incoming interns. And I went, well, we've built this whole program, we might as well do this for the whole entire country. And I really got to thank W.L. Gore, because they kind of stepped up and, you know, by and large, fund probably 70–80% of this. So you'll see and meet Jason Archinall, who's the Gore representative, a little bit later. The other person who's going to help run this is Dr. John Eye. He's from Baylor in Dallas. He is renowned for his whiteboard. And so that's why this thing is set up here. He's going to sit down here, and he's going to interrupt and basically clarify things that we say. Our faculty, led by Dr. Peden, will be kind of in and out, will help, you know, as they can, basically up in the lab. And you'll also see a lot of our residents and fellows. That's an opportunity for you to actually pick their brains. So this is not about how you deal with a ruptured aortic aneurysm, okay? This is a lot more basic than that. And we're trying to impart to you the tools of the trade that you're going to need, you know, a couple of weeks from now when you actually start. Now, unfortunately, this year, we could only take 40 because of the capacity issues that we had, but there are about another 40 who are watching this online. Now, that makes this a little bit different because we're normally pretty loosey-goosey in terms of sticking to the timeline because what they're doing while we're talking is they're setting up the lab. There's a bunch of cadavers up there, and I know you're all eager to get up there and get your hands bloody. But we're going to be a little bit more trying to stay to the timeline so that if people want to watch this online, they can actually chime in. There's also an opportunity for them to ask questions, and you guys can interrupt anytime. Again, the only stupid question is the one that you're too afraid to ask, because I guarantee you that's the one that will probably come up basically in your first couple of weeks. All right, we're going to start off with what seems pretty basic, vascular H&P. What's important to us? It's important to us when you're on call that you distinguish between urgent versus elective. And that's not that easy, in all honesty. Sometimes it's pretty obvious, but you know, this is a whole range of black all the way to white with lots of areas of gray in the middle, and trying to make that judgment is not that easy. We want you to be able to identify the ischemic limb, okay? And again, I think what Dr. Pede and I would say, if you're not sure, you push that up the ladder. What will get you in trouble is if you're sitting somebody with an ischemic limb and the attendant comes in the next day and goes, oh my Lord, you know, you've only got a matter basically of 6 to 8 hours in a lot of these patients. So if you're in doubt, you know, push it up to your seniors. Do not be intimidated by the seniors like used to happen to us. Be strong, which meant don't bother calling anybody. That is the wrong thing to do for these patients. So trying to identify urgent versus elective, particularly as it regards the ischemic limb, because that's what you're going to see more often. If it's a ruptured aortic aneurysm, your senior's going to be flooding in. But when you're in the hospital on your own, you're going to spend the rest of your life looking at feet and groins and legs and trying to figure out, you know, the urgency of this. Nobody wants to be operating in the middle of the night if we don't have to, but at the same time, as we do not want to miss that opportunity to revascularize the patient. Sick versus not sick. I always remember when I was around in at Emory, I'm standing outside the patient's room, and resident was presenting, and labs were normal, patient basically was okay, hemodynamics were stable, labs looked great, chest x-ray was fine. Well, that's good. Walk in the door, and it's obvious from the door that this patient is circling the drain. And that's what we mean by, one of the questions you will often hear you being asked is the patient sick? That means we got to be doing something urgently. Doesn't necessarily mean an ischemic limb. It may be either septic from an operation that you've done or something like that. But you got to figure out whether the patient is sick or not sick. And those are the ones you need to escalate up the ladder. Move it along. And recognize that imminent threat, and then, as I say, the last thing is know when to call for help. Eric, you want to put, can we get Dr. Peden a microphone? Oh, here, I'll give you this one. Good surgeon, but challenged by microphones. Yeah, it's all right. All right, H&P. There is a reason that there is a systematic process to do this, because you will not miss things. On the other hand, we don't want to hear all the drivel. We want it to be succinct in the presentation. And so obviously we're focused particularly on what the patient's symptoms are. Is the patient having the TIA? Okay, what's a TIA? Okay, TIA is very specific. We don't want to hear this patient is dizzy, or they may be dizzy, they may tell you they're dizzy, but you need to know, be able to cut through the chase. The weak and dizzy is not an indication, basically, that the patient's got carotid disease. Carotid disease is very specific, typically. Now, there are variations on this, but, you know, I in the clinic say, have you lost vision in one eye? Have you found, basically, you couldn't speak for 15 to 30 minutes? And the reason I basically say that is, if you say, ever found that you couldn't get the words out, everybody and their grandmother's going to say, oh, yeah, yeah, and then you're going to get this litany of things that's actually happened, and none of which, you know, are relevant. You know, those are the kind of things that you will learn is the vascular specific symptoms that it's your job to actually elucidate. Now, in addition to that, though, we all need about the previous medical histories. And the easy way that I cut through this, have you got any heart problems? You got any lung problems? You got any kidney problems? Have you had any vascular operations? And understanding what the previous vascular history is, well, probably one of the most important things that you can actually elucidate, because increasingly the patients had multiple interventions, and trying to figure out what you're going to do for that patient in the future is a big issue. The review of systems, again, that's really designed for you to help us pick out the heart disease, the lung disease, and the kidney disease. But when you present this to an attending, nobody wants to hear a whole litany of all of the different review of systems that you've gone through. And then we're going to show you a video that actually Dr. Peden made, basically, of the vascular physical exam. And so, when you come to present this, it's an art. You need to learn to boil this down to the relevant things. And because that's what we really want to hear. This is a 55-year-old man. He has got a long history of claudication. It suddenly got worse last night, and he presented to the ER. His previous medical history, he's had no previous vascular interventions in his lower leg. We're going, great, this is great, because once they've had multiple previous interventions, then the complexity of revascularizing that patient goes up. He's got a history of atrial fibrillation. He stopped his anticoagulation a couple of days ago, and on physical examination, he's got no pulses in his foot, no signals in his foot, no pulses in his popliteal, no signals in the popliteal. And the next thing we're going to be asking you is his calf tender? Okay, examining the calf in the anterior compartment, again, is one of these important things. If the patient's tender in the compartments, then you're going to operate on that patient that night. It's one of those things. If the patient has no signals in their foot, by and large, 80% of the time it's probably going to be an emergency. Not always. If the patient's completely asymptomatic and no signals, they've probably been gradually occluding the blood vessels basically over years. But those are the kind of things that we want to elucidate. Eric?
Yeah, I would say one of the things to me is I want the teaser up front, right? Because the problem is this guy could have like a bazillion medical problems, and you're listing all these different things and all these different findings, and at the end you're like, and we're asked to see this carotid stenosis, and I'm like, hang on a second, I'm still thinking about his foot disease, his arm thing, his AAA, and blah, blah, blah. So I think it's really helpful if you start off with, you know, this is a 55-year-old guy we asked to see for acute ischemic limb. And I'm like, okay, mindset, framework, got it, go forward, fill in the blanks, and then give me your assessment plan. I would say the other thing is, the crucial thing you've got to do when you start seeing this patient, besides seeing this patient, is what? Give me that. Besides talking to the patient and examining the patient.
Choose somebody. That's a slight challenge. Normally this is very interactive.
Yeah, so tell me, what's one of the things you want to do?
Go through this.
Like order, if we're doing a
So I would say one of the most crucial things you got to do is look in the chart, right? Almost certainly this person has some kind of history. Very rarely are these vascular patients just born de novo. They've been to the hospital before, they've seen somebody in clinic, they've had a CT scan before, there's been a previous arterial Doppler study, et cetera, et cetera. For you not to know that is ridiculous, honestly, right? Because it's right there, and for your fellow or attending or whoever to come by behind you and go, dude, you didn't tell me about the FemPop you had last week. Because the problem is, so Dylan, what's the problem with the patient giving you all the history and physical?
Well, it's their version.
It's their version, right? It's what this old guy remembers after he's had his strokes and dementia and slapped around by his family and whatever else, right? And has spent weeks, months, whatever in the hospital. So the problem is the patient recollection of these events may be really poor. So you've got to look in the chart to see what else has happened before.
Yeah, we're going to ad lib because the folks online can't hear a word they're saying. So we're going to pass the microphone. That way you can at least predict when you're about to be on the spot. So let's start down here. As you ask questions, you pass it to the next person, and then the folks who are watching online.
Well, that makes it clear who's next, I guess. Yeah.
Huh?
That makes it clear who's next. But anyway, so really, really important, guys, right? And you don't have to peel through, a bazillion things, right? If you're going to go and look, the highlights for you are going to be what was the discharge summary, right? So how many admissions and whatever, and you can just kind of go to the bottom line of discharge, diagnosis, whatever else, and then what operations has this person had? So if I have to go to the EMR, like those are two things I'm going to look for first, right? And then from there you can kind of tease out what else is there. But absolutely crucial because the information is there now, right? It's no longer the thing of, well, medical records couldn't find the chart. Those days are gone, like the days of Alan and I's training. So really, really important. It's the thing that's going to make you shine, or the main thing that's to make you look pretty dull and rusty and need a lot of work.
All right. Give us your name. We'll eventually learn some of your names.
Tony.
Where are you from? Or what program are you going to?
USF.
All righty. Okay, we're trying to teach you how to describe things, okay? This is a patient who had a carotid endarterectomy. I'm not going to tell you who did it. Their initials happen to be ABL, unfortunately. And so this is not good. So tell me, so I did the carotid endarterectomy, patient comes back to the clinic, you walk in and see him, and I go, patient doing okay? I said, well, what do you see?
What I would say more commonly, Tony, is the PACU nurse calls you and says, ooh, we think this person's having a stroke.
Yeah, that's a great point.
So I see a elderly female who has an uneven smile. Looks like the left side isn't really doing anything, but she's sticking out her tongue and it's midline.
Actually, it's supposed to be pointing to the left. Okay, it's pointing to the left a little bit. Yeah, you're off to the right. We'll get you a pass on that one. All righty. So,
Stroke team?
stroke or no stroke?
Nurse is poised, right?
What side was
Chipotle is
that?
getting cold. You got to get back to that.
So we did the endarterectomy. What side was it on?
Left side.
Left side. Do we hit the hypoglossal?
You have what?
The hypoglossal?
Could it be the hypoglossal? Yeah, it could be the hypoglossal. The hypoglossal nerve supplies what? Is it going to feed back through this thing? Hypoglossal nerve does what?
I just know if there's a palsy or if you bag it, the tongue sticks out to that side.
Points to the side of the lesion, okay? Hypoglossal nerve sticks your tongue out, so if this side's not working, it points to the side that you injured it at, okay? So patient's got hypoglossal nerve injury. What about the face thing?
Not sure what her baseline is, but it seems to...
Not this.
Not this.
Ma'am, is your face usually twisted? No?
So it's pulling to the right, it's paralyzed on the left. Come on up here, John. I got you set up right here for you. So she's got a marginal mandibular nerve palsy on that side too. So almost a full house in this particular case. The only thing we're missing is the vagus nerve. So again, we don't necessarily expect you to know what all these things are, but you're going to be on the phone, calling somebody, describing, and you got to be able to accurately evaluate the patient and describe what they've got. Can we get another one of these velour microphones for Dr. Wright, please? Okay, so the whole point of this is to record the patient's symptom at the time of presentation, organize these, and lead in a systematic fashion so that you don't miss relevant parts, basically, of the presentation. I think we've probably covered the majority of this stuff. So I'm going to play your video, Eric. This is how Dr. Peden recommends we do a vascular physical exam. This is going to be good. You're going to be telling him how he's doing it completely wrong, huh?
This video demonstrates a comprehensive physical examination for vascular surgery patients. The complete examination is best done with a patient laying down either on a stretcher or an exam bed. Initially is to take a good look at the feet, look in between the toes at the heels for any skin lesions. Next, a palpation for the pulses, both dorsalis pedis and posterior tibialis. A Doppler examination is also important to make sure you're not being deceived by feeling your own pulses.
Happens all the time.
Dorsalis pedis is often most easily identified at the anterior ankle, and then the normal location on the dorsum of the foot, over the second metatarsal, and also important to listen for flow down by the toes. If challenges in finding the signal there, you can move the probe laterally and medially in that space. Similarly, if problems finding the posterior tibialis, you can move in between the medial malleolus and the Achilles tendon to identify the artery. Next, palpation for the popliteal pulses. You need some patience here to depress in the area with your fingers. Hold there for a second until you feel the pulses. A general estimate of how big the calves are, looking for swelling, can be done by simply looking at how your fingers overlap as you examine both sides. Examination of the femoral pulse is important.
This is one of our fellows, by the way. You think, it's very close to our program director.
And to be done bilaterally to compare. Auscultation for bruise can be reflective of stenosis or disease or the presence of fistulas. Auscultation of the abdomen for bruise can be rapidly achieved. And a simple palpation for obvious masses. Next, an examination over the heart.
Oh, come on.
Listening over both sides of the sternum.
Universal listening point.
And next, listening to the lung.
Does everybody have a stethoscope?
Lastly, listening for carotid bruise with the patient doing a breath hold. And then palpation for any masses in the neck or periclavicular region. Again, inspection of the hands for any lesions and palpation of radial pulses. This completes a comprehensive physical exam for the vascular surgery
All right.
patient.
And Eric, any comments where John dives in and starts criticizing us?
Don't give up your stethoscopes. You will pick up murmurs. You will pick up bruise. You will find things. So don't leave that behind. I think you really do.
This video will demonstrate vessel
sorry.
mapping for dialysis access.
Yeah, this is running through our videos.
Important
Let me stop
ultrasound
that.
controls include the
All right, back to this. Sorry, Eric, go ahead.
Yeah, I just think it's important to actually listen to the patient and use a stethoscope and listen for bruise and murmurs and stuff. I mean, you'd be surprised at how few people actually have a stethoscope still and exam for these things. You say, John, there's no point in picking up asymptomatic bruise?
It's an interesting, actually, I thought what you did was very practical because that's what we do. We start with the feet because we're trying to figure out if we're going to have to do something today. But most people like to have, I usually go from clean stuff to dirty stuff. So I usually don't go from the feet to the neck just because, especially in this COVID era where people are so sensitized to whether you squirted stuff on your hand when you went in the room and are you, sterile and all kind of clean, that kind of working backwards, in fact, though, is what you do, because if you got pedal pulses, you don't really have to worry about if there's going to be popliteal or femoral pulses,
Can I pick up on that? So you'll see a lot of people get sent to you for pain in your legs,
Yeah.
okay? Generic, you'll see that every week in clinic. And first thing we do is put your finger on the foot. And if there's a palpable pedal pulse, they almost 99% don't have lower extremity occlusive disease. And so that allows you to fast track moving through this. Now, you're left with trying to figure out what the pain is, but that's an incredibly practical tip. Palpable pedal pulses, you're probably off the hook for lower extremity occlusive disease.
And fundamentally, it says with all surgical physical exams, you're looking for cases. It's like when you do a general surgery exam, you're looking for thyroid lumps, you're looking for neck masses, you're looking for breast masses, you're feeling for the gallbladder. Somebody told me that one time, and I thought it does kind of help to direct you when you're doing a physical exam. And here, obviously, you're listening for carotid disease, and you're feeling for an abdominal aneurysm, and then you're checking for, femoral and pedal pulses. The only other thing I would say is that it wasn't an issue here because you had two men, an exam of a man and a man, but I never do a female exam without a chaperone in the room, especially when you're doing femoral pulses. I just think it's prudent for the men in the room, at least. Now, I don't know what the deal is with women. I don't think we really emphasize that as much for y'all when you're examining a man, but certainly for a man, I would have a chaperone in the room.
You mean for a woman examining a guy? Is that what you're
No,
saying?
I was saying, I don't know whether you guys ask for chaperones when you examine men. I mean, we're pretty well, I think, tuned into the idea. I wouldn't do a physical exam on a woman without having a chaperone in the room for the most part. What do you think about that? Do you?
Yeah, if I'm getting up close and personal, then yes, that's right? Part of it depends on the patient. I mean, obviously, there are old ladies you've been seeing for 10 years and stuff.
Yeah.
And, I think that's not really an issue. I guess my main point of making this is that it doesn't have to be a belabored 20-minute physical, right? I mean, you can get the stuff you need. This was non-edited of 3 minutes of hitting top to bottom, checking all the salient pulses, and doing a relatively good general physical exam. Obviously, I didn't go through, extraocular movements and blah, 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 if the person seemed grossly neurologically intact. If they had a stroke, obviously your exam would be a little bit different here, right? I don't know, you worry about pop pulses.
The part of the exam I find people miss most frequently is they just don't try to do a popliteal exam. I find that not a good thing, because if you've got femoral and popliteal pulses, it's a wholly different. When you're dealing with dialysis patients and diabetics with mostly tibial disease, a much different animal in terms of what are you going to do next. And if you don't take that effort to feel for popliteal pulses, well, you miss potentially popliteal aneurysms, but also you just don't know what the distribution of disease is. We jump to this imaging thing, but with a decent history and an appropriate physical exam, we know exactly what we need. The vascular lab is adjunctive, and so the CTA kind of, specifies, but you know what they've got as you walk out of the room, generally speaking, after you've done a decent history and physical. I know that sounds kind of archaic with, modern imaging and all, but the reality is that vascular is very much a history and physical business, and you can have a pretty good idea what the arteriogram is going to look like before you do it.
Yeah, absolutely. The other thing is that you may have missed it was just trying to assess what the size of the calves is relative to each other. Is truly just touching your fingers in the back and seeing where your fingers overlap in the front. It's like crazy easy simple. It takes you like 10 seconds to do. But you can see, wow, this is like 2-3 centimeters different than the other side, or this is roughly equal. And then you don't have to go get a tape measure and do all kinds of stuff.
How do you record the magnitude of a pulse? Do you use a scale, or do you say it's normal, or what do you do?
I basically say normal, diminished. So our thing says palpable, non-palpable, Doppler roll, or absent.
Okay.
And I think that's important for you to kind of think about as you're doing your exam, is if you don't feel it, you should have a Doppler with you so you can do that, right? Especially for you guys this coming year.
But don't do this. I can't feel it. Go get a Doppler, locate the artery, and then kind of go into a trance and say, yes, I can feel it now. Because that's not what you're trying to do. What you're trying to do is transmit information to the average human being who is going to come examine this patient at a later point in time. They're going to walk up, feel for a pulse. They either can feel it or they can't. You don't want to try to you're not trying to demonstrate how sensitive your fingers are. There's no benefit, because if somebody else doesn't take that time to try to get into this kind of seance with the patient, and you're in rhythm with the moon to feel their pulse, it doesn't do any good. You can feel it or you can't. Can't feel it, write 0. If you can feel it, it's a 2. If it's asymmetrical, it's a 1. That's a simple rule. If you can feel it, and even if it doesn't feel very strong, but if you're the same on both sides, I usually call that a 2+. 1+ basically means it's asymmetrical. One femoral is strong, one femoral is weak. One other thing.
Never heard that definition before.
Huh?
Never heard that definition, that 1 plus means asymmetric.
Well, it
Just make
basically
that up?
it means it's not as strong as the other side. Even if both sides were weaker, it's hard to know what's normal. But asymmetry, I use 1 plus basically for asymmetry. And 3 plus, I don't know what that means. And 4 plus, I definitely don't know what that means. Sort of aneurysm. Yeah.
Yeah. I mean,
Sometimes you use 3 plus if it's just a massive, big, aneurysmal popliteal pulse.
Yeah. But to emphasize what Dr. Rai was saying is that it's the symptoms and then trying to correlate the exam to the symptoms. And based upon that, we're trying to figure out what the intervention is going to be. So, okay, pass the microphone. Tell us your program and your name.
I'm Carla, and UT
Carla?
Yes.
Yeah, which program?
UT Southwestern Dallas.
All right. Oh, competition. Give her a hard time.
Oh, we're a team. We're a team.
All right. So the patient comes in and they've got right buttock claudication. Tell me the physical exam.
So I would.
Loud and proud. Dr. Payton says loud and proud.
And
You
sometimes
can be wrong,
completely
but at least
wrong.
be dogmatic about it. You're a surgeon now.
I would try to feel the femoral pulse.
Yeah.
Will be probably absent.
Absent or diminished. Okay, on the right side. Completely asymptomatic on the left side. What's the left femoral pulse?
Yeah, probably 2 plus.
Probably normal. Well, a night 2 plus, 2 plus, 1 plus. What about the pulses going down the leg?
Then probably popliteal on the right will be either diminished or absent, and dorsalis pedis as well.
All right.
And then on the left, probably everything will be either normal or diminished popliteal and diminished dorsalis pedis.
And okay, perfect. So where's the lesion?
Probably in the either aorta or the iliacs
Left side's normal.
so it's probably iliacs.
Iliac, simple stuff. Simple plumbing. That's basically what you're dealing with here. Okay, patient says they got pain in their calf.
Then probably femoral will be symmetric.
Normal
or
femoral pulses.
Bilateral. And then popliteal will be diminished.
Diminished. Where's the lesion?
On the femoral.
Which
or
femoral?
On the right.
Right side, which blood vessel? No, we're going to have to start being specific in the anatomy.
Okay, sorry. So
Likely. What's it likely to be?
superficial femoral on the right.
Superficial femoral artery. Almost certainly. Not completely, but probably. Okay. So obviously right there you have a pretty good idea what the procedure is going to be to do the intervention. You're still going to get the imaging, but you know exactly what the patient's likely to have. Okay? All righty. DP, you can pass it along. Be ready. We're coming your way. Again, I was always taught, take the big toe, wiggle the big toe. You see that extensor hallucis longus, and it's usually about a centimeter lateral to that. So if you can't find it, that's one of the areas you're going to be looking at. Eric already talked about the posterior tibial artery. I typically put my finger in the front of it, my thumb in the front of the ankle, and my fingers directly behind the medial malleolus.
I would say one of the challenges of that is when things are edematous, right? So when things are edematous, my move is to push in to kind of displace the edema. So I do that for a couple of seconds, and then I'll just lighten up, right? And once you lighten up, then all of a sudden you can feel the pulse start going again.
Yeah, that's exactly right. It's kind of the same thing with the popliteal. You create more pressure than you actually need, and then kind of as you let off is where you start feeling the pulse. But the edema thing, and you see this an awful lot. And of course, you won't because you won't ever go to clinic. But for those of us who actually see patients in a clinic, residents don't have to do that anymore. But when you're seeing people raw off the street, you don't have these workups already done. So squeezing through the edema to feel a pulse is a big relief because you're trying to figure out what are you going to have to do today. And if you can feel a pulse, bingo, you've moved on to another problem. Alan and I probably disagree about whether you use your thumbs. I don't find that my thumbs are very sensitive for feeling pulses. So I actually do similar to what Eric did. I use my right hand to feel the right dorsalis pedis. I use my left hand to feel the right posterior tibial because I want to use my fingers. So I kind of cross over for the dorsalis pedis, and then I go ipsilateral when I'm doing the posterior tib. And I find that gives me my best chance of feeling a pulse. The other is, never try to feel a pulse in somebody sitting in a wheelchair. You will try to do this because it's a big pain in the butt, Somebody comes in, they've had a stroke, they're sitting in a wheelchair, you're concerned about an ulcer on their foot, and it's going to be a pain to get them out of the chair and up on the bed. But if you want to feel pulses, get somebody to lay flat. Also, don't have them sit on the table and look down and watch you and try to point to what the problem is, because as they're sitting up, there's something about sitting, the groin crease, the inguinal ligament, I don't know what it does, but it just, or maybe it's just the fact that they're tense and they're kind of fighting you. Get them to lay flat. If you want to feel pulses, lay them flat and have their legs relaxed. The other thing too is if somebody has just run into the clinic and jumped on the bed, you may not be able to feel a pulse, and 15 minutes later you might be able to. Why would that be? You think it's because you're more tuned into their needs? Or?
You're on the hook. I don't know the answer either. So
Well,
we're going to have the same boat.
if somebody goes to the vascular lab and they're going to check your ABI, how long do they let them lay there before they do the ankle brachial index? You're supposed to rest for a few minutes, so your heart rate and blood pressure aren't up. You're at high flow. If you're at high flow and you've got a proximal stenosis somewhere, it'll diminish the pulse downstream from that. It becomes a critical stenosis. Whereas if they lay there for a few minutes, their heart rate and blood pressure come down, their pulse may become palpable, where it wasn't palpable when they were energized and their muscles are kind of opened. It's a basic kind of physiology thing.
Yeah, I do think it's important to get in a relatively comfortable position when you're going to examine for the pulses, because if you're doing some kind of weird behind the back and wrist twisty thing, your exam's not going to be reliable. And then somebody behind you is going to be like, dude, it's like a banging pulse right here. How'd you miss that? What are you, an intern? Right, and then that sets off a whole cascade of stuff.
Yeah, if you want to impress, it's not really the perineal. It's perineal divides into two branches, but there's often a branch that you can detect round about the lateral malleolus. So if there are no other signals, you get a gold star if you hear a signal there, because it keeps us in bed at night. The Allen test, everybody know how to do an Allen test? Actually, we have a video somewhere of it. Maybe this is it. Yeah, this is Cara.
How to perform an Allen test. An Allen test is used to assess blood supply to the hands. Locate the radial and ulnar artery and occlude vessels. Have the patient clench and unclench hands. Make sure the vessels are occluded. When the patient opens fist, hands should appear to be blanched. Next, release the radial artery, and if color returns to normal, that means perfusion shows patency of the palmar arch. We turn our attention to the ulnar artery. Once again, we locate the radial and ulnar artery, and vessels should be occluded. Have the patient clench and unclench hand. The hand should appear blanched at this time. Release the ulnar artery, and if color returns to normal, perfusion shows patency of the palmar arch.
It's like a million variations on how to do this.
Yeah, I don't do the clench. I don't see the point of, you're trying to exsanguinate the hand. So one good squeeze, occlude the vessels, relax the hand, release a vessel is what ultimately what you're trying to accomplish. A couple of the failure points on this is if you have somebody hyperextend their hand as they open it, my hand's blanched just from the fact that I've kind of held it out taut. So they're just supposed to relax the hand and then follow it. And it's an important test, because you will see people who lose their thumb and index finger from an A line because nobody bothered to check that their ulnar artery was intact. And you can just start writing checks if that happens. Nobody goes well when they go to court and they only have part of a hand when they say, who did this to you? And they point to you in the witness stand. So it's an important test. It's not a minor test to do.
I mean, the variants in this are like putting a pulse ox probe on a finger and then occluding one artery than the other, so that you don't have to do the blanched unblanched thing, because that's the part that's a little bit variable. Plus, as they're moving those tendons, that displaces your fingers, and that becomes a little tricky. The other thing is just to locate the palmar arch with your Doppler, which is much lower in the palm than you'd think. Listen to that, and then occlude one then the other. Those are kind of ways around that.
So if you're looking for the palmar arch where your thumb meets your palm, that's the line across where you're really listening for a signal. It's not out by the metacarpal heads.
Yeah, it's one of those things that's unreliable as it may be. first thing somebody's going to look for is that it's documented and it's short if you put an art line. And you will be putting art lines in people. And increasingly, we're doing transradial access. So, and every patient we do transradial access on, we document that the ulnar artery is patent and it's filling the palmar arch. I hate to think the number of radial arteries you lose when we're actually sticking it and working through them.
Yeah, at the very least, when you're putting in that that radial artery art line and you're doing it with ultrasound, sweep over and just confirm there is an ulnar artery there, right? If there's only one big plump radial artery and you don't see an ulnar, which happens all the time, that's a disaster waiting to happen if you put the line in that artery. So at the very least, make sure they've got one, because if they don't, it really doesn't matter what's happening with the arch.
Yeah, and again, it's, if you've made an effort to assure that there's collateral circulation in the hand and you document it and then you have a bad outcome, you're never going to have any liability for that. On the other hand, if you had there's no evidence that you assured that the hand had sufficient collateral circulation and then you take out a big portion of the hand with an A-line. There's just so much in the literature, especially anesthesia and critical care literatures, that emphasize the importance of checking collateral circulation that it's just not defensible in this era if you lose a major part of someone's hand, unless you could claim that it was just such an emergency that there was no choice. But then you don't want to do that, so just write a note. I checked the collateral circulation, it was adequate before I put an A-line in.
Is that what you write? I checked the collateral circulation, or I
think
did an Allen test?
It's an interesting question. Is how do you document what you do? In some ways, if you write too much, you're putting more noose in the chart. There's more stuff to hang yourself with. We were guided to write our post-op notes for post-op day 1, routine post-op course, sign it. It gives you a lot of wiggle room when someone comes and asks you a question, well, did you know the hematocrit was 12? Well, of course I knew. I made a decision about that. I made a professional decision. I've had, intelligent people tell me, your whole goal is not to write everything down. Now, the ICUs, they write a lot down because they're getting paid by sort of their documentation, but it is, I think, a general statement that I checked collateral circulation was adequate. You can always just, explain how you did that at a later point, but if there's no evidence that you did anything, then it's I think, a little more challenging.
Yeah, so probably the only pulse we haven't talked about is superficial temporal artery. Where is it? Do you know where it is? Where do you examine it?
I mean, that's in the temporal region.
Yeah, okay. That's a gimme. Okay. That doesn't inspire me with confidence when you call me in the middle of the night to say the acutely ischemic head.
You could do worse. You could do worse for sure, right?
Because you're going to operate on it. You're going to take it out the next day. You can't make a decision this long. You got to know where it is. Anybody know where it is? Yeah, any idea? Yeah, well, describe it to me, though. Pass it along. Okay. Describe anatomically where you would find this thing.
Who are you? Sorry.
Jerry Victor, going to LSU.
LSU. Okay.
So I forget my ear anatomy, but is this the tragus?
Your ear anatomy. Your tragus. Very good.
It's like right next to the tragus.
Yeah, but up 1 centimeter in front of the tragus.
Yeah.
You should be able to feel it. Everybody feel their own superficial temporal artery? And the operation that I detest most is superficial temporal artery. But I've had more complications with superficial temporal artery biopsy than from aortas, because you think it's a piece of cake. We used to do it in memory. We do it in the office with the patient awake. It was totally miserable. Down here, we basically take a patient in the operating room, put him to sleep. We take this thing out, and it's a whole lot easier because it's not always that easy to find this thing. And it's usually about 1 centimeter in front of the tragus. The way we do it is take a Doppler, map out where it is, and then make a decision. It's usually about 0.5 centimeter to 1 centimeter deep in there. But that's the only time it's really going to be that important to you. Okay, keep it. You're up. Describe the findings. We're going to go 1, 2, 3. You're on the left. Again, you're called, you're seeing the patient in the hospital, Dr. Wright's on call, and you're going to tell him what you see. All right, let me give you some symptoms. Patient basically was admitted through the ER on the medicine service. They had a little bit of a swollen calf. It's gotten worse in the past 24 hours, and they want you to come and have a look at them. No tests have been ordered yet.
So just by looking at it.
Use the microphone. Can't hear you.
So just by looking, the color seems to be the same for me on both sides.
Okay.
And the right leg seems to be more edematous than the left.
How do you know the left leg's just not real small?
Sure. So it's asymmetrical, right being bigger than the left.
Now we give you the history. Okay. What else? Describe the leg. Is it the ankle? Is it the calf? Is it the knee? Is it the thigh?
I mean, the asymmetry looks to be the whole leg to me.
So, okay, so that's an important piece of information to actually deliver to us. Okay, the whole leg is swollen, from the ankle all the way up to the groin. Okay, remember, you're the plumber. You're just the plumber here, okay? And when you examine it, the sensation is normal, and he's got, once you get through the edema, palpable pedal pulses. What are you thinking?
So if he has palpable pedal pulses, it means the arterial flow is good to the leg, so it's probably a venous problem. Obstruction.
Okay.
So I'm thinking that there's an obstruction past the femoral system. So like iliac's probably, iliac.
Oh, well, which side of the circulation are we working on here?
Which side of the what?
Circulation. Arteries, veins, lymphatics.
I'm thinking it's a venous obstruction.
Okay, so
Like iliac.
by and large, arterial obstruction does not give you a swollen leg. Now, if it's been persistent for a few days, it'd be swollen. But this patient's only been here for less than 24 hours, and so the whole leg is swollen. And it progressed from his calf basically up to his thigh, okay? So you're thinking what?
So now I'm thinking arterial.
I'm saying, hold it closer, I can't hear you.
I didn't hear everything you said, but if it's not venous, I'm guessing it's arterial.
No, don't back up, right? You said it's palpable pulses, swollen leg. Don't let him talk you out of what you already know.
Oh, I think it's a venous. I think it's a venous.
Yeah, stick with it.
occlusion.
Stand your ground. It's absolutely venous. There's
Okay, yeah.
absolutely no question.
Yeah.
I didn't hear everything you said.
So Dr. Wright, this patient has, just present the patient to me.
So
Just make it up. Yeah.
So this is a 65-year-old male, I guess, with progressive swelling, whole leg swelling that started from his calf, and now it's whole leg, and it's more swollen than the left
Right.
side.
Does it hurt?
Does it hurt? Yes, he tells me it hurts.
So it hurts.
Yeah.
Okay. Previous medical history. What would you want to know in this guy? You're right. The patient's got an iliofemoral DVT. Okay.
Yeah. Mm-hmm.
So you got the symptoms. You got an anatomical obstruction. What else do we want to know?
So I want to know if he's anticoagulated.
Okay.
I want to know if he has a history of
Yep.
any thrombosis or.
Yeah, excellent. Most common, highest risk factor for having a DVT. Haven't had one in the past. Okay. So we always want to know if this is the first time or they've had previous DVTs, particularly in that leg. Okay. The other thing is what prompted this. That's what you're always kind of working at. We worry a little bit more about things that just happen out of the blue. Risk factors for this could be previous surgery, okay, airplane travel, injury, something like that. The sort of things that we're trying to elucidate in the history. Okay?
Jerry, what do you see at the top of the screen?
At the top. Are you referring to his
Loud and proud. Can't hear you.
So there's a scar, right? And the scar is still pinkish. So it looks like in his left lower quadrant he's got a scar above some fold or something.
Oh, on the
like,
left side?
Yeah, you're like,
Oh, I
what
see.
is that? Has this guy got a kidney transplant, or he's just had some kind of colon surgery? Who knows exactly?
Yeah.
But recent procedure on this guy would be really salient because presumably he's got a yes on his leg. He's going for some kind of procedure which may involve TPA, and TPA in the setting of recent surgery could be a real problem.
And they got him tied down, so he ain't laying out on the ward. So someone has made a decision that something's going to happen. And there's blood on the floor, so that's always a...
So in general, the other things are, if you're going to intervene on this patient, always good to think about lytics, okay? And that's another one of these things you got to document in advance. If it's a DVT, are we thinking about using lytics, TPA? Have they had intracranial bleed? Have they had head trauma? Have they had a recent stroke? Have they had GI bleeding, GU bleeding? Anything that is a contraindication of that, because that is one of those things that get you sued if you've got a patient with a recent stroke and we start pumping TPA into them. Okay, Dylan, you're up next.
The only other thing I would add on the history on a guy like this is you're calling somebody in the middle of the night. We want to know, can they move it and feel it? If you can move it and feel it, the clock just got set back. The urgency drops away. Can't move it, can't feel it. Now all of a sudden you jump into a whole different category of urgency because now you can't wait forever. Whether it's arterial or venous, when you start having neurologic changes and motor changes, the urgency jumps up. So, and we don't, and again, we're not neurologists, so we don't need very fancy neurologic exams. It's the same neuro exam you do in trauma. They can move this wing, and they can move that wing, and they can move the other ones, their flippers move. That's all we really want to know. It's not that detailed, but the same thing here. If it's asymmetrical, you know, one leg he's not moving very well, his strength is not very good, he's got tenderness, you feel the calf and it's, you know, it's hurting when he moves. That's a different animal than if there's no pain or there's minimal pain and he's got normal sensation, normal movement. The clock ticks back a little bit and takes off the urgency.
I can't tell you how much that drives people crazy. I mean, nature likes symmetry, right? So if you call and you're like, hey, he's got this wound on his toe and I can't feel the pulses, I'm waiting.
Yeah.
How about the other side?
Yeah.
Yep.
Silence on the other end of the phone. Like, dude, for the love of God, go examine this person because I just showed you can do it in 3 minutes, right?
Yeah. Yeah.
Yeah, I mean, if you've got no pulses on the right foot and it hurts and it's tender and you've got palpable pulses on the other side, first of all, that's really good for us in terms of trying to actually revascularize this patient, but it also starts pointing towards etiology. It's likely it's an embolus that has gone down there, as opposed to an occlusion. And when we talk about that, we're really thinking an occlusion is patient's got previous underlying peripheral vascular disease, now they've thrombosed on top of it. Well, you're not pulling that out with a Fogarty catheter, which is the quick and dirty procedure and then back into bed. That's going to be a long-term procedure, either lysing the patient or bypassing them or something like that. Okay, Dylan, mellow one.
Yeah, so not just the etiology, but also potentially the urgency of that, right? If they're totally normal on the other side, then we really want to get them back to normal. If they've had long-standing vascular disease, pretty unlikely that's going to be something that has to go in the middle of the night.
Theme around there, but I think most importantly is his or her entire hand is blanched, and it's all white. So it looks like this patient maybe is thrombosed their radial artery and doesn't have an ulnar artery. It doesn't look like it's a
So
arch.
examine his hand though.
Okay.
Particularly in a situation like this, okay? Your observations are right on, but you haven't really told me the impact of this in his hand. So now you're going to examine the guy's hand.
Okay. So first to see if he had any sensation or motor at all in his hand still, and then would feel for a radial or ulnar pulse. It doesn't look like he have either. And then...
Okay, he's got an ulnar signal.
Okay, an ulnar
and
signal.
And he's got a signal in his palmar arch.
Okay.
So you're looking at it.
So,
give me your hand, say, squeeze my hand. Simple
okay,
stuff.
okay.
Squeeze my hand. Basically makes you scream, you know, there's not much wrong with his hand. And then briefly examine the sensory aspect of his hand.
Okay.
And so once you've done that, you've established that his hand is not threatened, or it is threatened, depending on what your exam shows. Now you're dealing with a local problem where that line went in. And what they're obviously worried about here is this thing is infected. Okay. So you think that radial artery is patent? Probably not patent.
No, I mean...
It's probably thrombosed, and it may or may not be infected. It doesn't look like it's getting worse based upon where those lines actually are. But what we're trying to figure out is whether we've got to go excise the artery because there's pus tracking up it or tracking along it. Got you.
Or it's an infected pseudoaneurysm or something like that. So the other thing I'd say is, again, you want to compare it to the other side, right? And not just in terms of color and motor, et cetera, but also temperature. So one of the simplest things you can do is just touch both extremities, right? Whether that's both feet or both hands or whatnot. Like the morning after a bypass for critical limb ischemia, if that foot's not warmer than the other side, something's going on, right? Because that foot should be hyperemic compared to the other side. And this, I would guess, has got some degree of ischemia going on, and you want to know, is it cooler than the other side? Now that can be deceptive if it's been out and exposed and the other one's been covered, but you really want to know about warmth of that limb compared to the other side.
Okay, pass it along.
Okay. Hi, I'm Melissa DeAndrea. I'm going to University of Arizona, Tucson in
All right,
June.
going to work with Dr. Zhu. She's one of our fellows here. All righty. Okay, describe it first before you think of etiologies. What are we looking at?
So we're looking
Let me give you a little history. This patient's in an ICU. They're semi-conscious, and they're borderline complaining of pain because they're in and out of consciousness, but the nurse says this is new in the last 24 hours.
Okay. So we're looking at blue fingers on the left hand, and the patient is most likely in pain. I would test for sensation, motor. Can you squeeze my hands?
Can't move it. When you squeeze, when you move her fingers, patient groans, so we presume it hurts, but she can't really move it spontaneously.
Okay. So name 2 possible etiologies then?
Yeah, so what do you think's going on? Yeah.
Yeah. I
But
think this
again,
is...
well, here's the other, what Dr. Peterman was saying. You got to look at the other extremities here, okay? This is sine qua non for you. You got to look not only at the other hand, you got to look at both feet at the same time. And so when you look at the other hand, it's not as bad as that, but it's kind of getting there. And you look at the toes are pretty dusky too.
Okay. So this is
And
definitely...
this comes under the sick or not sick. This comes in the sick as shit category that
Right.
you're starting to look at here.
This could be a systemic issue, possibly sepsis or throwing acute emboli.
Okay. So the patient had open heart surgery, had trouble coming off a pump. This is going to open chest. There's on a bunch of pressors.
Okay, so acute limb ischemia.
Okay, so well, yeah, qualify. I mean, she's got it's vasospasm that this patient has got, and it's probably because they're on all those pressors. And then they want to know, when do you want to operate, doc?
I think the patient is too unstable
has a
to operate.
good radial and ulnar signal, a reasonable radial and ulnar signal. You can't hear anything down in the digits. You can actually remember there are digital arteries run on each side of these digits. You can listen to those in a Doppler. Nothing.
I think the problem is the pressor requirement, so you
Okay.
can't really intervene without.
So the answer is thank you for the invitation to operate. We're not going to be operating.
Yeah.
We
We will
You're going to have to
decline
wean this
it.
patient off pressors and resuscitate them because there's not really anything surgical for you to do in a situation like this. Emboli, could be emboli. Typically, the patient's not in an ICU on a bunch of pressors when something like that happens, and they're going to tell you these hurt badly. Any comments, John?
No, I was going to say, that was a good description. Almost always emboli are going to be asymmetrical. You know, if you look at somebody's hands and they've got 10 digits and they're all blue, well, that's a systemic problem. If you got 3 on one hand, well, that's probably not a systemic problem. It's amazingly seems obvious, but it's an important finding. You're not going to have it's virtually impossible to like have 20 digits all embolized simultaneously. So that symmetry issue in the ICU patient, and again, you know, it kind of strikes me as we're going through some of these physical findings. I mean, what's hard for you guys is you don't know anything. And so
Exactly.
when you're trying to direct, we're constantly problem solving with the physical exam and the history. We're kind of being selective about what you do. It's not the medical student history and physical where you do a comprehensive physical. Everything we do is directed toward answering a problem. And until you know what the problems are and the differential, it's hard to know what to do next. So it's a kind of a, you know, your left hand, your right hand have to, it's just, that's why it takes a long time to get to do this damn stuff, is because you can't do it efficiently without being able, without having some knowledge about what you're trying to answer. What are you trying to solve? So these are tricky questions, I think, because again, you're problem solving as you do the exam. And so then when you call your attending, you're constantly in this mode of, guess what I'm thinking, or you know, what's the trick answer here? Well, if you knew everything, you wouldn't have to be a resident and go through it already. So tough luck. It's going to be hard.
Okay, who's next?
With that.
Hi, everyone. Good morning. My name is Omar. I'm coming from Lenox Hill in New York City. So starting with the image on the left, so we have a foot here. It seems edematous. I see some strict demarcation of discoloration beginning on the lower foot, going up towards the ankle. It seems like the foot was also marked for pedal signals as well. So given the discoloration, especially the strict demarcation, I'm concerned about some sort of limb-threatening ischemia.
So those X's represent the pulses.
Yeah.
Pulses are present.
Okay. So if pulses are present, maybe some sort of infectious etiology given the swelling, maybe also a burn. It could be a blister that's right above.
Is it just swelling, or can you characterize anything more about that? Top of the toes, top of the foot.
Yeah. I don't know how else I would describe it besides swelling and maybe the blister right above.
Blistering,
Yeah,
right?
blistering,
So blister
yeah.
is important to say that, right? Blistering with surrounding erythema. Because that's clearly going to point us in one direction or the other, right? I mean,
Yeah.
you can get, blistering as, a really ischemic foot has progressed on beyond salvageability, and now the tissues are separating, et cetera. But usually that's not an early sign of arterial ischemia.
Okay.
Febrile, white counts going through the roof, hurts.
There's also a funny finding there, I think. It looks like a surgical incision that's healed over a kind of a metatarsal incision.
Right there.
It's kind of a weird looking, it's a weird foot.
Yeah.
You're not going to see many feet that look like that, but it's...
But again, it's distinguishing serious versus not serious. This is serious, okay? This is a serious, limb-threatening infection. We don't exactly know what the etiology is here, but the fact that there are signals in the foot probably means it's not an acutely ischemic limb. It's probably something else, and it's likely infected.
Make sure you don't say someone has a Doppler pulse. What's wrong with that?
Pulses
A pulse is something you feel with your fingers, or what? Some part. It's something you can feel. It's not something you hear. So if you say in the middle of the night, if you call an attending and say the pulses are present, what you mean is I could hear a Doppler signal. That's entirely different information. So if you call and say I can feel pulses, or I can't feel pulses, but I can hear signals, that's different. So don't conflate. There's no such thing as a Doppler pulse. Those don't exist. So don't ever say that, because we're getting a totally different message if you say pulses are present. What you meant was I hunted around with a Doppler and finally found a signal. Totally different animal, okay?
Yeah, you need to be clear. Pulses are present, they're palpable, or pulses are only present by Doppler, right? I mean, so they're only Dopplerable or palpable, or
everybody
absent.
that's alive has got a pulse by Doppler. So just call it a Doppler signal. The safest thing is to call it a Doppler signal, not a Doppler pulse. A Doppler pulse really doesn't exist in the English language.
Okay, next, your chance to shine.
My name is Lindsay. I will be going to the University of Pittsburgh next year.
All right.
Who's the program director?
Dr. Scher, Robbie Scher.
Okay.
Who's the chief of the division up there?
Still Dr. Macaroon.
We know him well. So we're going to toughen you up here a little bit over the next couple of days.
That's good. You can get me ready. All right. Well, I see a pretty deep foot wound on this patient. I think that eliciting some history here would be pretty important, knowing some of their underlying medical conditions.
Diabetic, end-stage renal disease,
Sounds...
foot swollen, hurting, but really doesn't hurt that bad.
Okay. I'd also want to know about how long this has been going on for them. It looks pretty chronic at this stage.
Yeah, it says at least a couple of weeks.
Okay. So then I would move on to do, just after inspecting it, I would move on to do my pulse exam on this patient.
What would you guess? You think there's pulses here or not?
I'm going to say no, probably not.
There's a kind of a hint that there probably are. I'm going to say there probably are pulses. What do you think it is?
Because it's a little bit pink there.
Well, there's pink, but there's something else that's
it's
more
bleeding.
characteristic.
It's a little bit there's like some blood there on the bandage, and
Well,
I don't know.
that. He's got a lot of callus.
Yeah, see that?
Callus is a poor man's vascular exam. It takes, fibroblasts have to have oxygen just like every other cell. In order to do their thing and make collagen, you got to have blood supply. An ischemic ulcer in a diabetic won't have a lot of callus around it. This guy's had a chronic malperforans, kind of neuropathic situation, fundamentally. Now, there may be some arterial component, but if you had to kind of pick one or the other, if they've got a lot of callus, probably there's pretty decent circulation. No callus, now you're looking at more of a pure ischemic ulcer. So you can see he's probably had a malperforans up around his third metatarsal head, and then he's got this secondary infection down on the fifth metatarsal, so there's probably decent circulation. Callus is a good finding, though. If you do podiatry, some of you will do a lot of feet. Some of your programs won't do a lot of podiatry for you guys, and some of you'll split it off to the podiatrist. But if you do your own foot surgery, trimming callus on these kind of people is kind of fundamental to what you do. And most of those people don't need revascularization. It's all focused on pressure relief and treating infection and debriding dead tissue.
So, foot looks pink. There's the huge callus around the outside. So the mechanism of this callus was probably confluent at one point in time. And what happens is these patients walk on this callus. It's like having a rock inside your shoe. And it damages the tissue that's deep to it. So when you examine the black stuff in the middle, it's probably very soft. So what do you want to know?
Whether or not it's infected.
What do you want to know about this?
I would want to know if it was infected. So
If you take a swab from that, I guarantee you're going to get bugs out of it. Doesn't necessarily mean it's co-infected per se.
Right. Would you want to debride it a little bit?
Before we get to that, you want to know how deep this is, okay?
Oh, yes.
These things are like an iceberg, only about a third of it's basically above the surface. The rest of it is deep. And the second thing you want to know is if it's just localized to that area or whether there's infection tracking back inside the foot. And it tracks back inside these plantar spaces that are in there. So one of the things you usually do is press into the sole of the foot and see whether the patient is tender in that area. Now, this guy's clearly it's neuropathic. His foot's deformed, and so whether or not they have normal sensation in it or not, but that's what you're really trying to determine is how deep that is and whether there's deep infection that's tracking back into the foot. If it's purely chronic, then you can deal with this electively. If they got pus tracking back in their foot, that's one of these things you drain emergently. Ulceration. So you're going to look at a lot of you're going to be reading feet for the rest of your life. Whether you like it or not, that's kind of what we do basically on a daily basis. And what you're really trying to do is distinguish arterial ulcers, venous ulcers. We haven't even talked about venous ulcers yet. And then your job is to evaluate the underlying blood supply. And so you've got to be able to do a neurological exam. And again, that's just, can you wiggle it? Can you feel it? And then check their pulses. Because your job is actually to revascularize this patient if there is a problem in the blood supply. Okay, who's next? What about this one?
So I'm Pauline. I'm going to Stanford. So here we...
Where are you at?
Where are you going?
Where's your program?
At Stanford.
Stanford? Okay. Who's the program director there? Is that Jason still? Or Vanita?
Oh, Chandra.
Chandra, okay.
Okay.
So here I see this patient, their second toe around the base of it is, it looks discolored. They have some hypertrophic nails on all of their toes. It looks like there is an open wound at the base of the second toe. And the first toe, we have some dryness and discoloration of the toenail.
Okay, so swollen, red, ulcerated. What do you think's going on?
I guess I would want to, get some history from the patient, see how long this has been going on, see if they had any trauma to the foot.
No trauma.
Okay. I would want to see if, what their medical history is.
Same story. Diabetic, smoker.
Okay. I want to know, I guess, how long this has been going on for.
So I'd be thinking this patient is a combination of peripheral vascular disease and superinfection added on top of it. And so typically what you're going to do is you're going to put them on antibiotics, you're going to cool it down, get rid of all that redness. At the same time in the background, you're actually starting to evaluate what their circulation actually looks like. I'm running over time. Okay, so acute ischemia. Guess we should talk about that. Who's next?
So I'd say on those things where you're seeing that toe wound, don't forget to look at the heels and stuff, right? Because not uncommonly they'll have a decubitus or something like that. And if you're dealing with forefoot and hindfoot tissue loss, that becomes much more likely to be primary amputation rather than limb salvage, particularly depending on what the patient's other things are.
All right, I'll give you the history. This has been going on for 10 days. You're getting called now. The patient can't move their foot. Their calf is tender. They are insensate, and it doesn't blanch when you put your finger on it. It's got that fixed kind of modeling. Okay. What's going on?
So I'm John. I'm going to Stanford. So this has been going on for 10 days. They can't move their leg. So this is maybe like acute on chronic limb ischemia. Just by the fact that they can't move their leg suggests that it's kind of progressed into Rutherford 2B. Maybe even 3 at this point because it's been going on for like 10 days. So absence of flow.
Okay, exam. No Doppler signals in the pop, no Doppler signals in the DP or the PT. They have a palpable femoral pulse.
Oh, well, it's not a cadaver. But it could have been. Up until that moment, this could be a cadaver.
No, it's pretty close. Sometimes the margins are pretty fine.
Yeah.
So he said femoral, no DP, no popliteal.
Yeah.
So probably an inclusion up in the SFA.
So what are you going to do?
I mean, if this has been going on for 10 days and they haven't been able to move their leg for 10 days, I mean, probably need to go to the operating room and see if there's anything salvageable, but I mean, 10 days, it's
Patient
kind of...
doesn't walk. That's the other question you always want to ask is, does the patient walk? Are they ambulatory? This patient non-ambulatory. They've been in a nursing home before they came in here. They got cardiomyopathy. This patient's going to need an AKA.
Yeah.
You're not going to be able to do anything else.
So you want to look at, can you actually move that foot or not, right?
Yeah,
I would guess you try to move that foot and ankle, and you can't move it. The problem is, too, is nobody's going to tell you it's been going on for 10 days. It's like they haven't been paging you for 10 days, right? This just got recognized as shift change when some, industrious nurse came on and pulled the sheets back and was like, whew, something clearly different on this side compared to the other side. So if they can't move, if you can't move the leg passively, that's what is that called? So that's rigor mortis, right?
Yeah. Mm-hmm.
So rigor mortis and fixed skin changes, that's beyond salvaging. That tissue is progressed to irreversible tissue damage.
Everybody needs to know the acute classification, Rutherford, right? A, whatever it is, 1, 2A, 2B, and 3. And you got to know that because the 3s shouldn't be revascularized. And you'll see people screw around trying to revascularize these people, and you wind up having heart attacks on the table and all kind of consequences that are systemic from just imprudent attempts to try to... That leg is dead. It's not resting. It's dead. When you have a dead leg, you cut it off. There's no messing around with that. I mean, you've got modeling like that. You can't move it, can't feel it, it's hurting. There's not a salvage option, so don't mess with it.
Yeah, so that's livedo reticularis, right? If you're looking at skin changes, that patchy skin stuff, and it doesn't blanch. If it blanches, that's still some blood flow, right? Doesn't blanch, those are fixed skin changes. That's dead tissue.
These sort of very, very end-stage findings. Blisters, those big blisters on the skin come up on these things. Those are end-stage legs. You need to be able to describe a leg that doesn't need revascularization at 3 in the morning and you're going to put them on for an AKA the following day.
Yep.
But I would say to not recognize rigor mortis and not check for that in one that's that ischemic, that's an error.
Yeah.
Because that's a really important finding, because exactly like Dr. Wright's saying, you take that person revascularized on a big acid wash, potassium wash, that's going to be a big disaster.
And if you put that guy in the OR and then your attending comes cruising in thinking they're going to do a femoral thrombectomy with a viable leg, and they walk in, they see this leg wrapped up, that's not going to look really great for you. You really don't want to
Hopefully
do
the attending
that.
seen the patient, but in the middle of the night, sometimes you arrive in the operating room, you don't really like surprises. So this is a classic myoperforans ulcer. It's a little more typical than the one you had before. You can see the callus around it. What's underneath there is the metatarsal head. So what happens in these patients is the neurologic disorder, and it leads to a plantar displacement of the metatarsal head. They walk on that, it gets that callus, then the callus kind of breaks down. And you look at the foot on the right, this is the typical Charcot foot, a massive deformity. And that's kind of what it looks like based on an MR scan. Okay, this is one for you, John. Hurts like hell, recent trauma, thought to be an electrical injury, otherwise healthy male.
Must be an infection. It's a cutaneous larva migrans. I don't know what it is.
Yeah, that's a Bowie injury, and that's my damn finger. And so you be careful when you actually get a hole in your glove and you get a Bowie injury, because you will get this, and man, they hurt like there's no tomorrow. You don't stand there going, oh, I just got an injury to my finger.
Has anybody had this happen to them? It's because you guys are usually holding the Bowie, and we're holding the pickup, and you're buzzing our pickup, and it burns through our glove. And when it happens, for the next few minutes, you won't do that again. You jerk your hand away as soon as somebody starts to bovie you.
Yeah, the other thing you're going to do a lot of is looking at wounds. That's all these post-op checks. And, that's a kind of an inexact science at best, but it's, again, probably worthwhile spending a minute or two and talking about what a wound looks like, because here's a femoral incision. You can see that it's kind of full. It's a little indurated, a little red. It ain't perfect, let's put it that way. It's not to the point that it's egregious, but what are you going to do about this? Probably just going to put them on antibiotics. You may get an ultrasound and see there's a big hematoma or something like that underlying it, but this is probably the sort of thing that you're going to watch for a couple of days.
But I'll tell you, there were clues before you got to this point, right? You look at the hospital gown. Is the hospital gown soiled with drainage from the wound? If so, yeah, expect to find something when you pull the gown back and the dressing back. You look at the gauze. Is the gauze fresh and clean and dry, or is the gauze like soaping with serous fluid? Because those are distinctly different things. If things are under the skin and staying under the skin, you've still got a chance with antibiotics and time. If they're coming out of the skin, then they want to be opened up and let them vent fully.
Bleeding ulcerated fistula. There's another one of these judgment calls. I always tell my horror story about this from memory. And when I was a new attending, got called. They said, it's not bleeding. It was bleeding. It stopped. Now it looks okay. Okay, we'll put them on the schedule for the following morning. 2 o'clock in the morning, that patient exsanguinated into their bed. These fistulas have got a couple of liters a minute actually going through them. And so you got to take these very seriously. If the skin is intact, you can probably do it electively. If the skin has got a hole in it, then you better be thinking about doing something about that urgently, either oversew it in the ER or take it to the operating room, because when these things cut loose, you will see a lot of these, particularly if you come on our service down here.
I don't know, those of you who don't know, Eric is one of the world's experts on dialysis access, but and we've generally got a philosophy at Baylor and Dallas is if you come into the emergency room with a bleeding fistula, you don't want to be the person to make the decision to send them home. We generally admit all bleeding fistulas. Not, that is, if they've got any little bit of an ulceration. Again, if it's just prolonged bleeding and the skin is intact and it was a puncture site and you're talking about venous outflow obstruction, prolonged bleeding, a little different animal. But if they've eroded the skin sufficiently to bleed, put them in the hospital, make somebody else make the decision to send them home, because you don't want to be in the position to say, oh yeah, I saw him at 2 a.m. and he bled to death in the parking lot at 4. These things are unpredictable. If they've bled, put them in the hospital and fix it. You'll never be wrong by making that decision, especially as a resident. You can't afford to send them out, I can tell you. So just bleeding fistulas need to get admitted.
Any comments, Eric?
Yeah. People die from it, right? There's multiple reports in literature of people dying from that thing. So you definitely have to have a heightened awareness.
It's funny, if you ask the CDC or somebody, how many people die in the United States from exsanguination from dialysis, I don't think there's a number that's really recorded, but everybody that I've ever talked to has anecdotal experiences like Alan's with somebody that's bled to death from this. And I've heard some stories at home where they walked in, there's literally blood all over the house where they couldn't get control of the thing. They're an old woman trying to compress her fistula. Not a good picture. So again, bleeding fistulas, if you remember nothing this week.
Yeah, so I think that's the other thing, right? So you walk into the ER and there's a blood-soaked bandage wrapped around this thing, and it's sometimes huge, right? Bed sheets, pillowcases, all kinds of stuff. And then somebody's got like an elastic tourniquet up higher, right? So you should be like, call my whoever, senior, attending, whatever, and be taking that thing down and try and get a finger right on the hole. Almost never is there bleeding you can't stop with your finger, right, for a dialysis thing. And a rubber tourniquet, that does zero for you, right? Now, pneumatic tourniquet, that can, but you're much better off putting a finger in the hole.
And then don't leave the patient. I mean, there's two situations, two bleeding situations that you're going to get called for. Number one is this, and number two is the bleeding groin. You get called up, and there's a big hematoma on the groin, and you need to put pressure on that thing, and you need to stay with that patient until somebody comes along and relieves you, or you make a decision about definitive treatment for it, because these are the two situations that patients can exsanguinate in very short order. Is there a role for tossing a few stitches in this? We've all done it.
Yeah, absolutely, right? That's a great temporizing move, but it kind of depends on getting good bites of good stuff, right? Almost always, like, think about good to good, really, really important. Yeah, I mean, two things I think you're gonna do to save more people in this coming year: hold pressure and give fluids. You do those two things, you can make it through almost all of internship.
Yep, fair enough. Okay, I really want to show you who's next. All right, you're up. Just focus on this one. That is a clue here, by the way. If you don't pick up that clue, you're done. It's impossible. We can't train you. Tell me what you see.
So I'm looking at. Hi, I'm Rosmi. I'm going to University of Buffalo.
Going where, sorry?
University of Buffalo.
All right.
So I'm looking at an open ulcer. I'd say about 7 centimeters.
Okay. Yep.
And it looks like it's on the lateral aspect of the foot, possibly.
No, you're on the medial aspect.
It's on the medial. Okay.
Right above the medial malleolus.
And there's
So describe it. What's it look like? See all that yellow stuff? You haven't even told us about that yet. That's why it's often easy to look at these things and not state the obvious. Just describe. Our recommendation is always just describe what you see, but look. It's like looking at a CAT scan. If you don't look for specific things, you miss it. But just go through the wound. We know that your leg look like that. You all covered in that yellow stuff all over down there. No. Okay. So what is that? What are we looking at?
So we're looking at yellow discoloration. It looks like there's also areas of possible necrosis with the darkening look. The edges are fairly demarcated. There's surrounding.
What do the edges look like? And what is two things we're looking at? Where's the ulcer? Size of the ulcer. What the base looks like, and what the edges are looking like.
It looks like a little bit like a punched out lesion. Maybe like it's deep. It's fairly deep.
Pretty deep. Not as deep as it was, is what you're going to be told. So it's pink, okay? It's not a nasty necrotic arterial ulcer. It's pink. It's got a lot of debris basically on top of it that probably needs to be debrided. You can either do that with a collagenase-based paste, or you can do it surgically. But there's hope for this. I mean, we look at this and go, the base is pink, looks like it's granulating, the edges are pink. That's a good sign for taking care of this. Is the leg edematous?
Possibly, but I would like to look at
it looks pretty
other
edematous. And again, edema is the enemy here. You're trying to reduce swelling. It's compression, 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 and local wound dressings here. Okay. So venous ulcers, the overwhelming majority are on the medial side of the leg, immediately above the malleolus. If you go see a patient and they've got an ulcer in the tip of their toe, it's probably arterial. If they've got an ulcer in the medial side of the leg above their malleolus, probably venous. Why? Why do you get venous ulcers on the medial side of your leg? This is where the next session comes in. Anatomy, anatomy, anatomy. Anatomy is an elective subject in vascular surgery these days. That's where the perforating veins are. Superficial veins, deep veins, perforating veins, which transmit pressure from the deep system, are immediately above the medial malleolus on the inside of your leg. That's why these ulcers form here. And that's why perforated ablation is one of the things that we often need to do. All right, I need to move on. Do you guys want to go grab a cup of coffee? Let's see, so, you still there? Are you doing the ultrasound upstairs?
Yes, sir.
Okay. What time? 10 o'clock? Dr. Garami. He's another one of our faculty. Okay, folks, grab a seat and shut up. Be the other way of putting it. This is Dr. Garami. He's going to be teaching ultrasound upstairs. Jason's his door, heavily supported this. So, Jason, you want to see him?
Appreciate you guys being here. I'm Jason Archinall with W.L. Gorn Associates. I'm on the peripheral side. I'll be here with you guys all week. We're going to go to dinner a couple of nights and hang out. One of the, I guess, negatives we got after we reviewed some stuff was we got one negative the whole time when they were submitting the reviews and all this, and it was that the Gore guy kept them out too late.
Oh.
So that's so we're not going to do that for you. So thank y'all for being here.
All right.
Great. All right, so I would say you're going to review a lot of imaging, right? Alan, for a long time, has said vascular is all about imaging, and it just proves to be more and more true over time. I would say there's two really crucial things you have to do when you're thinking about the imaging studies that you're going to get. Alan, you want to pass the mic to somebody?
Who's got the mic? All right.
All right.
I'm Brandy. I matched at Emory.
You where?
Brandy at Emory.
Welcome.
Thank you.
Okay, so two things you got to do with this imaging study is you're kind of trying to interpret it. And most people do one of two things. So you're told to go check out that CAT scan on the patient that you were worried about for whatever problem.
Right. So you need to properly orient yourself to what imaging modality you're using, and then you also need to make sure that
ultrasound versus CAT scan. Yep.
Right. You also need to make sure that you look at multiple planes of the image.
So you need so more basic than that, right? Again, this is pre-intern. This is not super subspecialty fellowship stuff on imaging. You need to look at the images, right? You absolutely positively need to look at the images, and
we're going to work front and back.
Look at the images and
it seems stupid to say it out loud. You need to read the report.
Oh.
I can't tell you how many times somebody's come and told me, oh, the CAT scan shows blah, blah, blah. And I pull it up, I look at the report, and I'm like, renal cancer, type 2 endoleak, visceral malperfusion, ischemic colon, mass, blah, blah, blah. And the resident has not seen that, right? So early on, the people are like only reading the report because they have no idea what they're looking at. And later on, they're only looking at the images and they don't read the report because they're God's gift to image interpretation. And there's no need for them to even possibly consider that a radiologist who's paid to do this full time and is board certified actually saw something they didn't see. John, you want to see this all the time?
Yeah, the only other thing I would say is make sure you look at the name on the damn thing. Because seriously, how many times you look at a CAT scan, somebody says, oh, he's got an aneurysm, it changed in size, you look at the name and it was the wrong name, or it was a date from 3 years ago. So look at the name, make sure you're looking at what you think you're looking at. And I would suggest to you, don't read the report until you've looked at the images. Because once you've biased yourself, you will think you can interpret everything. Oh yes, I would have seen that kidney tumor. I would have seen the hydroureter. I would have seen the adrenal mass. Look at the images first, then look at the report to check yourself as opposed to otherwise. Because while it is true these guys are board certified, they're also doing, TSA assembly line stuff. And you're sitting there watching one suitcase after another go by. It's easy to miss a gun in one of the bags. So, they're looking at a gazillion of these things. You've got history-directed information. You're looking for specific things. So you've got a better chance of finding stuff. And you really should be able to interpret a CAT scan better than most radiologists because this all you do is look at them. So look at the images first, then look at the report.
There's a caveat on that. You're probably going to be better at looking at the vascular stuff. There's a lot of stuff on the CAT scan that can really burn you. And one of the things that will happen to you is the lung cancer, okay? And that's why looking at the report is important because you order the CAT scan and the radiologist reports lung cancer and you're looking at this 4.5 centimeter aneurysm saying, okay, we'll get another scan basically a year from now. They come back and they go, oh, well, by the way, doctor, the lung cancer is bigger, but the aneurysm is still the same size. It's your problem at that point in time. And that will happen to everybody. So there's a lot of things on the scan other than just the vascular component of it.
But absolutely crucial. Look at the images, look at the report. If you don't, you're definitely going to miss stuff. And you have kind of a purpose-driven image interpretation that you're doing. So some comment on mural thrombus or whatever else it is, although some people get all excited about, oh, there's mural thrombus in the aneurysm. You're like, not symptomatic, not really that impressive, not including the lumen. So to you, that's kind of an innocuous finding, whereas the radiologist spends a lot of time describing it, morphology of it, and blah, 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 blah. But absolutely crucial. Look at the images, look at the report. If you don't, you're definitely going to miss stuff, and you're definitely going to shortchange your stuff in terms of how you progress, in terms of ability to manage to interpret these things. You want to pass it down then?
So we've got 2 microphones now, one in the front, one in the back. You can bounce backwards and forwards. The back row's falling asleep. So we need to encourage them to stay engaged.
All right, great. So what are we looking at here? What kind of imaging study? Let's just start there.
A CT scan?
It's a trick question, right? Because first you got to introduce yourself and say where you're from.
Hi, I'm Alex Barone, and I'm going to University of Minnesota.
University of what?
Minnesota?
Minnesota, okay.
Okay, so go ahead.
What kind of
So
scan
it's
is
a
it?
CT scan, yeah. Is that it?
What is it?
A CTA?
Is it a CTA?
No,
It's not a CTA, right? Why is it not a CTA?
because the arteries are not lighting up.
Because, say it again?
They're not lighting up with contrast?
Yeah, so we actually don't see any IV contrast. If there was IV contrast, it's given so long ago, it's kind of homogenized throughout the whole thing, but my guess this is a pre-con CT scan. So as we're looking at it then, right, we want to sit down, we want to play with the window levels, right? Panraj will go through that with you, because you want to be able to differentiate calcium from contrast. And the way it comes over pushed through packs, at least in our systems, they're blended in together, and you universally have to change that. It's strange when you actually sit with the radiologist and watch them. They don't often do that. They sometimes just leave that contrast level, glaringly white, just like we do with ultrasound contrast when we're doing our gain, right? All knobs to the right.
It's funny. It is
It is strange the way that they do that. And okay, so as you go through and you look at this, I'm just going to kind of flip back and forth here. That's something I'd want you to see. And what can you say about the aorta?
There is calcium?
There's calcium. Is it all over the place?
No, it's specifically like in the arch. Is
Yeah,
it
it's
there?
focal right here,
Yeah.
right on the undersurface of the arch, right? Yeah, let's pass the microphone down. All right, so structures. What do we have here?
Hi guys, I'm Maria and I'll be at Montefiore in the Bronx.
Great job, not falling into the trap.
I think that's the ascending aorta,
Yep, definitely the ascending aorta.
so that'll be the descending aorta.
Right.
If it's not part of the aorta, I
Okay,
probably won't get this. So
Yeah, that was really good stuff. And here?
there's air, is it the esophagus or
So-
trachea?
So much more likely to be the trachea, right? The esophagus shouldn't be all big and
Massive like
dilated
that,
unless there's some
sure.
kind of distal obstruction. This structure, a little more challenging. So here beside the aorta,
IVC.
to the right side of it,
Too small.
some big other structure joining it as it loops over the right mainstem bronchus and then joins this.
IVC.
So not the
SVC.
IVC, right?
Superior
Because we're in the
vena cava.
chest. So the SVC, right? And draining right down into the right atrium there. So I got to say, like as a fellow, there are lots of things that I never looked at that now I look at a lot, right? So aortic dissections for me as a fellow in vascular surgery, very, very little reason to look at any of that stuff. At most, we offered a fem bypass, and that was it. Now, like me looking at the arch and aortic dissection, all this stuff, really salient, it's something you pay attention to. Same thing with this, right? So this big structure here, this inverted Y,
The aortic arch.
so the aorta's here, ascending and descending. Whoop. See if I can play that again. So there's the aortic arch, right? And that funny thing coming off the bottom. And now, yeah.
So think anatomy. I mean, again, this is where you're going to look at anatomy in 2 ways. One in an operating room, 2 in an angiogram, and 3 in a CAT scan are the main ways you're going to be looking at it, but they're not divorced from one another. They're all part of the same anatomical structure. So what's inside the aortic arch? There's the left ventricle, which goes to the ascending aorta, and the right ventricle goes to?
Pulmonary arteries.
Pardon?
Pulmonary arteries.
Pulmonary artery. So this is the pulmonary artery, right? Again, for me as a fellow, almost no need to look at this. Read the report. Did the person have a PE? No PE. Honestly, at that time, we're doing more VQ scans than CTAs. But now you're going to be looking at that a lot because you're going to be offering pulmonary embolism interventions, right? So pulmonary artery there, branching off into right and left. So really important to look at that and to kind of think about where those structures are as you're going through.
So it's kind of interesting because so first of all, this is an axial slice, non-contrast CT scan, okay? And so can you go back one, Eric?
Yep.
If you can get to that. Whenever on an axial slice, you see a long segment of an artery, it's running horizontally, otherwise you cut through it. So it's amazing when you look at the main pulmonary trunk, it's running almost directly posteriorly horizontally. And when that's relevant to us is when you put a catheter and a wire up there, it usually ends up going into the left PA. It's a lot more difficult to get the right PA because it comes off at a little bit more of an acute an angle. Yep. All right, what's this? Let's go to the back row. I'll help you keep them awake back here. All right, tell us where you're from.
Is this on? Yeah, okay.
Yep.
My name is Arvind. I'm at Baylor College of Medicine right next door.
All right. So what are we looking at?
This is a CT scan of the abdomen.
What kind of CT scan?
Contrast CT
probably.
scan. Yep.
And coronal, axial, sagittal.
Sorry, contrast was yes or no?
Yes.
What kind of contrast?
I would say oral contrast. I don't see the vessels.
There's definitely oral contrast, right?
Yep.
Or it's passed through all the way to the lower GI systems. That's been in there for a bit.
And I'm sorry, I missed a question from you.
How is this slice being represented? Is it coronal, sagittal, or axial?
I think this is a coronal CT because we're looking kind of frontwards on.
All right, point out some structures, Eric. See if you can name them.
So on the right side of the image, the patient's left, you see the descending colon full of contrast.
See this arrow? He's going to show you some stuff.
Okay, so right in through here in the middle.
That is the aorta.
You're going to spend a lot of time looking at that.
Yep.
Both sides here.
What was that?
The renal arteries.
Right, so the renal arteries, excellent.
Yep.
Characterizing here.
So that looks like an aneurysm sac.
Yeah, so it looks like an infrarenal AAA, right? And now looking at the terminal aorta.
So that looks like some calcification kind of near the aortic bifurcation.
Yeah, very good. So as we go down through, we want to look at the iliacs, right? Because we want to make sure that there's not big aneurysmal change down here in the iliacs.
What are those muscles on either side of the aorta? What's that?
The psoas major.
Psoas major. What's inside psoas major? You're doing great, by the way. That's where the lumbar plexus lives, okay? And so when you get retroperitoneal hematomas, particularly hematomas forming inside the psoas, you got to examine the patient to see if they've got a femoral nerve palsy. And the way you do that is you put your hand on the thigh and you ask them to raise their thigh up against resistance. And so that's one of the indications to operate in these things semi-emergently. It doesn't happen very often, but it's because it is a contained space inside the psoas major muscle. And that's where the femoral nerve comes out of. All right?
And here to the right.
Yeah, what's that? Big structure to the right of the aorta.
IVC.
IVC. You see the renal vein, right renal vein?
Mm-hmm.
Where's the left renal vein run?
It sort of crosses over
Yep.
the aorta.
Most cases.
Yep.
Sometimes it's retroaortic. We need to pick that up on the axial slice CT scan because when you operate on them and you put a clamp on anteriorly, if you've not recognized that and you clamp the aorta, rips the renal vein posterior, and that's a very difficult thing to deal with. Good job. All right, you're off the hook. Dr. Grammy, you're up.
You want to kind of be able to characterize what the iliacs look like, right? So in this case, we would say not aneurysmal, but heavily calcified. So important to kind of notice that as you're looking at your vessels. All right.
All right, tell us about the scan. We're up the back here. What's that?
Hi, I'm Daniel. I'm going to Georgetown.
Awesome.
So that's the spine.
So what kind of scan is it? Always start off with.
So this is a sagittal oral CT.
Sagittal CT with oral contrast. Okay. All right, Eric's going to point out some blood vessels coming off the aorta.
So he's pointing right now to the bladder.
Yeah, important to look down there, right? 'Cause sometimes the bladder is huge and you realize a person has some kind of obstructive problem or something else like that. If they're majorly constipated or have obstipation, big time impacted, that's good to notice. So again, to kind of get a sense of what's going on with the non-vascular stuff. You're thinking about your procedures, thinking about your procedures and stuff, kind of nice to notice how much sub-Q fatty tissue there is, right? Is this a really big person with all kinds of fat, or is this a really lean person? That can be pretty salient in terms of how you're thinking about what you're going to do.
What is that? Again, this is all about pattern recognition, and you'll get used to this. Whether you're shooting an angiogram or whether you're looking at this, you're looking for the patterns of the blood vessel.
I think that's the SMA.
Okay, that is the SMA.
And that's the celiac artery.
Right. And how would you characterize them?
I'm sorry?
Would you characterize them at all, or?
The video looks like there's some stenosis in the celiac artery in the proximal region.
And what's right below the superior mesenteric artery in front of the aorta? Can you point that out, Eric? What is that? You get a gold star if you get this one. All right. So
I want to say the IMA, but I don't think that's the IMA.
No, IMA is lower down, coming out of the aneurysm. That's the renal vein, okay? Same renal vein was talking about crossing the front of the aorta. And that's why I say everything is on these scans. If you kind of look at it and think anatomically what it does, you're just cutting across the left renal vein. And that's where you divide it. For example, if you're going to treat a pararenal aneurysm or juxtarenal aneurysm, you divide it between clamps. And can you divide that renal vein? You got to put it back together again. That's a question. Can I chop the renal vein in half, or do I have to actually re-anastomose it at the end of the case?
I think you have to reattach it.
Almost never, okay? And the reason is because of anatomy. Because it's got the ovarian vein or the gonadal vein coming off it, it's got a suprarenal vein, it's got a big old lumbar vein coming off the back of it. So you can almost always divide the left renal vein without having to put it back together. It's not that easy to put it back together again. Okay, good job. All right.
Hi, I'm Sammy Assey. I'm going to Cleveland Clinic. So right here is a axial view CT with oral contrast. And we're looking at the aorta right below the kidney, so the infrarenal section of the aorta.
See the renal vein there? I'm going to show you. That's the renal vein, okay? And what's right in front, so you go aorta. You see the renal arteries coming off it? Immediately in front of the aorta is that left renal vein again. What's that thing right in front of the renal vein?
That would be the SMA.
Good job. Well, what's nutcracker syndrome?
That'd be whenever you compress the renal vein with the SMA.
Very good.
So here we have a coronal view CT with IV contrast.
All right.
Yeah, so I'd say if the student is pulling this up and showing this to you, this is one of those that you want to window, right? Because this looks like it's the same patient as what we've been looking at. And here, where we know there's all kinds of heavy calcification at the aortic bifurcation, we can't really clearly see that compared to the IV contrast. So we need to play with those contrast levels and window the image so we can see differentiation better, so we can tell calcium, right, like in the bones, from the IB contrast. And they are somewhat different densities, but it's going to come over to you like this, and you really want to play with it to be able to see that better.
You also know they were pretty lost because they have oral contrast and they got IV contrast. And generally speaking, you don't want all that GI contrast. If you're looking at vascular issues, all that does is confuse the picture. So if somebody's gotten all that contrast, it means whoever's taking care of him is clueless at this point because they're just throwing hand grenades at the wall trying to hope they find something. It's a late view. You see how late the contrast is in the liver? So this is typically your CTAs are going to be timed earlier on, so your region of interest in the CAT scan is going to be where you're most interested in the blood vessels. You won't wait. You specifically would have to delay your imaging to catch all that portal vein stuff. So this is quite a different kind of a scan than you'll see mostly.
Yeah, so typically when you order these scans, you got to decide what you want to look at optimally. So for example, if it's an aneurysm and an endoleak, then they do pre with no contrast, post with contrast, which they try to time for aortic filling, and then a delayed, which ideally is timed for the dye arrival through the lumbar arteries inside the aneurysm sac. But you may get very poor venous opacification. So if it's the venous side you want to look at, you order a CTV, not a CTA, and they'll time the dye arrival into the venous system.
All right, so tell us what's going on right here. And I would say kind of the one view is no view things. You want to be able to scroll back and forth, but focus right here. I want you to describe what you're seeing there to us.
Yeah, so there was the aneurysmal infarenal section of the aorta, and it looks like you have an aneurysmal section of the right iliac. But
of the right, what iliac?
Right common iliac.
Right.
And then it looks like you have...
Because bifurcation is here, if you look closely and watch the branching pattern. Okay.
And it looks like they have a patent left common iliac as well, but it's not aneurysmal.
Mm-hmm. Okay, what about all this stuff?
He called that. Yeah.
Is that like a ulcer of the wall of the aorta?
Say it again.
Is that like an ulcer of the wall of the aorta? I mean, sorry, of the iliac?
So ulceration typically looks a little different, right? Sometimes you see ulceration where things are actually coming outside. You can see ulcerated plaque, where things are kind of contrast level is punching into plaque and coming close to the arterial wall. It's not. So inside of an aneurysm, do you expect for the entire thing to be flow lumen? That's a question.
No, that'd be like thrombus against the wall of the aneurysmal sac.
So this is exactly that mural thrombus stuff that you're going to see reported, right? So then medicine resident or somebody's going to see this and say, hey, this guy's got thrombus in the aorta. I'm starting a heparin drip and blah, blah, blah. We think we should put him on warfarin or Eliquis or what exactly? Comes the question to you. It is thrombus.
It is thrombus, but it's not occluding anything
thrombus
right
and
now?
atheroma in reality.
I'm sorry, can you say that one more time?
In reality, it's actually kind of a mixed thrombus and atheroma. Does it need anticoagulation?
Maybe.
I'd say by and large, most times not, right? If this person's having embolic events, then you got to think about what you're going to do about that. But most commonly, this is not something that's symptomatic, right? So as the artery expands and becomes an aneurysm, in general, the body wants to maintain a relatively uniform flow channel. And we'll maintain that flow channel, we'll kind of build up around that with mural thrombus and atheroma and other things that kind of fill the cavity of that aneurysm. It's very uncommon that the entire aneurysm is full of swirling blood. It just doesn't happen like that.
All right, you're off the hook. Hey, can you go back that one and go up to the portal circulation, because it's really beautifully demonstrated, yeah. Okay, what do you know about the portal circulation? Tell us where you're from, first of all.
I'm Christina, and I'll be starting at Duke.
At Duke, all righty, going to go with Cindy. All righty, talk me through the portal circulation. What, you want to point out parts of it, Art?
So that's the portal vein.
Portal vein.
To the liver.
Yep. What makes the portal vein? There's one of them right there. What's that?
Splenic vein.
That's the beautifully demonstrated splenic vein. What's that? The spleen.
Yes.
Do vascular surgeons ever take spleens out?
No, I don't think I've seen a splenectomy done.
You need to come here. Yeah, so what's coming, we probably do more spleens than anybody, because when you do thoracoabdominal aneurysm, it's not unusual to tear a little piece off the spleen. And when you do that and you got an anticoagulated patient, just take the spleen out. So you don't really need it. What else forms the portal circulation?
You should have your mesenteric veins joining.
Which mesenteric vein? There you go.
Your IMA, right?
IMA is an artery.
Sorry, your inferior mesenteric vein.
No, superior mesenteric vein. So splenic vein, superior mesenteric vein, and it drains up and to form the portal vein. Are we ever, and what's the relationship between the superior mesenteric artery, well, there it is right there, and the superior mesenteric vein? Nobody can ever remember this. It's the same relationship as the aorta and the inferior vena cava. So when you're exploring the SMA and the root of the mesentery, remember there's no pulse in it at that point in time, otherwise you wouldn't be exploring it. And then you come across the superior mesenteric vein, do I go to the left or do I go to the right? Patient's left or patient's right to find the superior mesenteric artery?
You said that the relationship is similar to the aorta, right? So then the superior mesenteric artery should be on the right.
No,
Sorry, the patient's left.
The patient's left.
The
patient's
right
left.
on the screen.
Exactly what we're going to do. Okay. You're right. Good. All right, you're off the hook. You want to go from the groin down, this one? All right.
Okay. So, you've been looking at this structure a lot.
That's the common femoral.
Introduce yourself again.
My name is Taha. I'm from UT Houston.
All right, close by. Okay, so yeah, common femoral artery and vein, right? Anything different in the surrounding areas?
It looks like there's some swelling.
All right, so if we look at this side compared to that side, distinctly looks different, right? Much more tissue density here and fat density there. Some other ominous findings in there?
Again, just this, if you're not sure what it is, just describe it.
Okay. There's some calcification.
So calcium in the bones. I don't see much calcium in the artery or the vein here.
Okay.
And I don't really see calcification out here in the areas that we're talking about, right? Because again, remember, calcium is very bright.
Mm-hmm.
So it's the opposite of bright. So it's very dark, right? In fact, it's as dark as this area out here. And this is air surrounding the patient.
Is there like an infection?
So this looks like gas bubbles or air within the soft tissue diffusely with some soft tissue edema.
Mm-hmm.
So again, don't say, I see infection, right? That's what Dr. Owens is trying to say, is report what you see. And what you see is gas bubbles in the soft tissue and inflammatory changes with edema in the tissues right above the left common femoral artery. So that's kind of troublesome. And if you look, it tracks here, right? Underneath the obliques, here on the lateral surface, on the patient's left side.
So go through the abdominal wall structure. So what are those two bright dots in the tissue anteriorly?
The inferior epigastric veins.
Inferior epic. Close. Inferior epigastric what?
Artery.
Artery. Yeah, the inferior epigastric artery. And what are those muscles that are sitting in front of it?
The abdominal muscles.
Abdominal muscles not going to cut it, my friend. I mean, you need to know a little bit more about abdominal muscles than just abdominal muscles. Let's say go make an incision in the abdominal muscles. Where are you going to make that incision?
All the way across.
It could be anywhere. It gives you
All
license
the way
to
across,
kill.
you're going to hit it no matter what it is. Yeah.
Anatomy, what is it? We're going to make you do sit-ups and see if we can point them out.
Do you want me to take my shirt off?
Do you want to take your shirt off?
I didn't know this was that kind of conference, but okay.
The rectus abdominis muscle. And again, that's something you'll see fairly regularly. And the inferior epigastric runs behind them. And every now and again, you'll see bleeding from the inferior. It can bleed a lot.
Yeah, so that can lead to big old rectus sheath hematomas, for sure.
And so if you see a hematoma that's the same kind of shape as this, only plumped up, and it's contained within that, there's nothing in the subcutaneous tissue, there's nothing in the abdomen, it's pathognomonic of an inferior epigastric bleed into the rectus, because it's contained within that rectus sheath. It hurts. It's not easy to find where the bleeding point is, actually. And then you see the 3 layers of the abdominal muscles laterally. So what are they? Superficial to deep.
External.
External.
Internal.
Internal.
And then transverse.
Transversus. External oblique, fibers run. And again, the reason this is important is when we make an incision, we have to identify which muscle layer we're going to do based upon the direction of the fibers. So external oblique fibers run.
Downward and.
Downward, forward, and medially.
Yeah.
Internal oblique fibers run.
Lateral.
Pardon?
Like more mid.
Yeah, they run upwards, forwards, and medially. And transversus runs, that's a gimme. Get this one wrong, we'll have to kick you out of here. Transversus runs horizontally. And so you split the external, you split the internal, you find the transversus, you often split it or divide the fibers, and then the next layer is going to be what?
The fascia.
No, peritoneum at that point. And that's how you do a retroperitoneal exposure.
Okay.
So you make incision laterally, divide the muscles, and you stay outside the peritoneum, and you pull everything over. And as you pull everything over, you're going to see, can you go down to the abdomen there? So kind of on the right side, all the colon's going to go, the kidney's going to come up, and then you're going to come up against the psoas major muscles. And this is when we take all of that up, and we can be looking at the bottom end of the aorta, we can look at the common iliac arteries, the external iliac arteries, how to do kidney transplants with an incision like that. All right. You can show your recti later. Next.
Yeah. So comment on the aorta here.
Oh, hi, I'm me, sorry. I'm Jen, I'm at Methodist. We're starting at Methodist. So this is a axial CT scan, and it kind of like there's just a small darker portion of contrast on the posterior portion of the wall.
Say it again, Jen.
There's a darker portion of filling on the posterior portion of the wall.
Okay, so what might that darker area be? So this is IV contrast. I would tell you it seems to be in either a really dilute phase or late or something else. Contrast.
Maybe like even an ulcer.
Yeah, so this is probably plaque or atheroma. And if you look at it, it's not smooth, it's irregular with indentations in it. So this is ulcerated plaque, right? So this person very well might present with atheroembolic events down to the feet. So kind of recognizing that and then thinking about that in terms of your planning, because this is a person with this, right? And if this person's getting an endovascular repair of their aneurysm, those wires and catheters going up through that ulcerated plaque very well could result in some kind of atheroemboli.
Want to show the venous structure?
Yeah.
At 7 o'clock. And what's that structure at 7 o'clock at the bottom end of the aorta? Go down a little bit there. Yeah. Inferiorly. Yeah, right there. What's that? What's that big structure?
Inside the aorta?
Huh? No,
Inside the
adjacent
aorta?
to the aorta.
What are you,
What's
sorry,
that?
what are you asking?
Is
Right
in
there?
the lower part of the abdomen.
Like is it part of the wall?
Nope. Separate structure.
This guy here. You see what I'm circling out, Jen?
Sure. Could you
Think
just
anatomy.
scroll
So I'm
a
going
little
to scroll up and down a little just to say again, one view is no view.
Yep.
I see something from the kidney going and joining that. Coming up behind the liver and going right up into the heart.
Oh, so IVC.
What do you say?
IVC.
IVC, that's inferior vena cava. There's a giant lumbar vein coming into it. Okay, those things bleed like hell. If you make a hole in that lumbar vein, we have to expose this when we're taking inferior vena cava filters out, for example, and the amount of bleeding you can get through these lumbar veins. So before we do that, we run up and down this, try to identify and map out where those lumbar veins are so we can get control of them before we actually open the inferior vena cava. So just clamping the top and bottom end of this, don't cut it. And the amount of blood you can lose through these lumbar veins is astronomical. And as you go up, so yeah.
So kind of focus right here for a sec. I'm just going to scroll back and forth.
Yep.
So this structure right here, what is it and why might it be important?
So is that a lumbar artery?
Yep, so it's a lumbar artery, and why might it be important?
Because you can cause, like if you don't have do like a pre-op spinal drain, you can cause paraplegia and have a lot of post-operative complications.
So at this level, we're down at the level of the kidneys, right? The kidneys are below, so we're
Right.
infrarenal. So exceptionally unusual to have somebody develop spinal cord ischemia and paraplegia or paralysis from infrarenal aneurysm repair. Not to say it can't happen, it can, but it's almost kind of a freakish accident at that point.
So worried about endo leaks?
Yeah, so much more common to cause endo leaks and a real booger because it's not just one, right? There's multiples down there. As you can see, these other things kind of swirling up towards, and taking one out seems to almost, incite the others to become more and more troublesome.
So we probably need to take a break, Eric, and then we'll head on upstairs. So at lunchtime, Ponraj Chanudarai, he's a physician who works with Siemens, is going to talk to you about CAT scans. This is the world you are going to live in. This is probably how most anatomy is going to be demonstrated to you. And although we've been showing you axial, sagittal, and coronal, that's really not the way it works. You have them all on a plane, and you line everything up. And what he'll say to you is there's nothing, in an angiogram that you will not find in a good CTA. And so it's really important to work with these. We'll go over some of this a little bit later.
That's tomorrow.
Tomorrow? Oh, are you at lunch? Who's
Fellas.
Oh, I'm sorry, it's our interns today. I'm going to.
What we did, we set up like a break area that when you are tired of treating cadavers, we'll have an ultrasound kind of just outside the cadaver lab. And I will ask like a pair of tubes come out to the ultrasound when we take a break. We'll have some ultrasound patterns to teach you how to see more, how to see the middle ultrasound guidance. But I just want you to focus on the cadavers, and when you're going to have a little bit of rest, there will be chairs, so you're going to sit down and really put your hand. So I'm going to be your kind of break room just outside the cadavers.
Okay. So one of the more important things you're going to learn here is to use ultrasound, okay? We pride ourselves as being applied users of ultrasound. We stick no blood vessel without using ultrasound, whether it's venous, whether it's arterial. And I can tell you that an institution like this, once or twice a year, somebody will be killed with a central line being placed. And the idea that you're going to do this without using ultrasound guidance is crazy. And you will be on the front line of putting these dialysis access catheters in. That's how you kill people. And so it's real important that you know how to optimize the use of the ultrasound and to understand how you can get in trouble if you don't know the right wire and device combination. So we'll see you upstairs. Visit the vendor booths first of all. They've been told to teach you the basics, and so they're being able to show you catheters and wires and things like that.